Okay, so today we are going to start our second class on new format AKP cases discussion. Today I have picked up very, easy cases, about 5 cases, which are common in exams. Now, most of the cases have picture in this book, and it's extremely difficult to understand through the pictures. Not all pictures are clear. So I have selected cases which has less pictures and are easy because this is a public class. I feel like we should be more comprehensive and try to keep the class like within 1 hour or so. Okay, so today we'll be discussing 5 cases. We'll start from 1.1, 1.2, 1.3, 1.4, and then 2.14. Okay, let's start. Are you guys with me? Is the screen visible to you clearly?
Yes, ma'am. Yes.
Thank you. Please kindly participate. It's a purely discussion class. So we have case 1.1. What do we have here? A male infant was born at 28 weeks of gestation. Okay. So before starting the class, I'll tell you, don't focus on the questions, nothing. You just focus on the scenario. We'll discuss about the scenario and then go forward to solve the questions. Male infant was born at 28 weeks of gestation, weighing 940 grams. So he was very low birth weight baby. He was ventilated for 16 days because of respiratory distress syndrome. He is now 25 days old and has been stable since extubation. He is in air and full on enteral feeds with a preterm neonatal formula. You are asked to see him because he has developed an increased respiratory rate and intermittent self-limiting apnea. On examination, the temperature is 37.9 degrees Celsius, heart rate 192 beats per minute, respiratory rate is 78 breaths per minute. He has cold hand and feet and a capillary refill time of 3 seconds over the sternum. He has a good chest movement and mild subcostal recession. Air entry is good and his chest is clear. The heart sounds are normal, but there is a 2/6 short systolic murmur at the left sternal edge. The abdomen is distended and bowel sounds are not heard. Liver is palpable 1 centimeter below the costal margin and there is no other organomegaly. Okay. So I'll just again highlight the most important points and summarize this case. This is a male infant. He was born preterm at 28 weeks. Now he is 25 days old. And he at birth, so he was a premature baby as well as very low birth weight baby. And he was ventilated for about 16 days after birth due to respiratory distress. And respiratory distress. After that, he has been on a preterm neonatal formula. Okay, so it was completely fine. He is in air. That means no ventilation required. Now he's completely fine. But right now, after 25 days, that is after 25 days after his birth, he has come to you with increased respiratory rate and occasional apnea. On examination, what do you find? The temperature is slightly above normal. 37.6 is normal. This is 37.9 degrees Celsius. There is tachycardia and tachypnea. So if we consider this baby, it's a neonate, right? 25-day-old. So baby is coming with 192 beats per minute heart rate, and there is tachypnea as well, 78 breaths. And along with that, cold hand and feet. So what does cold hand and feet indicate to us?
Sepsis, ma'am.
Shock.
Oh.
Yes, you're right. You're thinking about septic shock. So more of, only when I'm saying cold hand and feet, more of shock. Along with that, capillary refill time is on the borderline, 3 seconds. Good chest movement, subcostal recession, chest is clear. So there is no respiratory problem. When they say chest is clear, we can kind of exclude there is no respiratory problem that we are suspecting. But he has a low grade murmur here, 2/6 only. That means no thrill. It's a murmur, it's audible, and there is no thrill. So 2/6 short systolic murmur on the left sternal edge. The abdomen is distended. Along with that, the bowel sounds are not heard. So abdomen distended with bowel sounds not heard. And now the liver is 1 centimeter. So this is normal for a neonate. So again, preterm baby come to us with very low birth weight baby. He was intubated, that is, ventilated for about 16 days. Now he's fine, but now comes to us with tachycardia, tachypnea, and along with that, basically he's coming to us with shock. Okay. Along with that, we can see the capillary refill time is on the borderline. The temperature is slightly increased. And then there are some other findings, that is abdominal findings. Abdomen is distended, plus there is no bowel sound. So what are our differential diagnoses for a neonate coming to us with tachycardia, tachypnea, slight rise in temperature? What are our differential diagnoses first in this case?
First one is neonatal sepsis.
Very good. That's what we studied in last class. First is always we'll consider sepsis. What is our second diagnosis we are considering?
NEC.
NEC.
Okay, NEC. Can you give your reasoning for NEC?
Distended abdomen and bowel sounds were absent.
Okay. So you said NEC. Okay. So, all right. NEC. What about the third?
Preterm on formulas, full formula feeds preterm for NEC.
Okay.
Feeding intolerance.
Yeah. Okay. So you have certain reasoning. Okay. We'll go back to the reasoning later. First differentials are sepsis, neck. What is the third differential you'd like to consider?
Ma'am, pneumonia because
chest is clear, so we are
yes,
kind of excluding pneumonia here. What else?
Meningitis, ma'am.
Okay, so we are keeping meningitis in mind. Okay, what else? Congenital heart disease. Yeah, we can keep that as well, congenital heart disease. Okay, not necessarily that all the points should be there. We're just keeping some things in mind. Okay, so with this information about a preterm baby, etc., these are our differential diagnosis. That is, first one is you're saying sepsis. The baby basically is in septic shock because there are features of shock. There is tachypnea, tachycardia, borderline CRT, along with that cold peripheries. So what are the points in favor of sepsis? The points in favor, whatever I'm writing here, as you mentioned, tachycardia, there is tachypnea, there is CRT borderline 3 seconds, then there is cold hand and feet. Along with that, temperature is slightly raised. Okay, this is our sepsis. What are the points in favor of neck? Distended abdomen.
Prematurity. Extreme prematurity.
That is actually, you're right. That is actually the first thing. Extreme prematurity, then
early feeding.
Yes, formula feeding. Anything apart from breast milk. Distended abdomen, along with that absence of bowel. Bowel movements are absent. That bowel sounds are absent. These are in point. That is, these are the points that are supporting neck. What about meningitis? Is there anything supporting meningitis here apart from the raised temperature?
Apnea, self-limiting apnea.
Okay, so self-limiting apnea here. So we are considering because of the temperature along with that apnea. All right. Okay. What about congenital heart disease? So this is our third differential. The fourth differential congenital heart disease is that we are thinking this could be a case of heart failure along with the congenital heart disease. But I have one examination finding here, which is telling me this is not a case of heart failure.
There is no hepatomegaly.
Grade 2
by 6 systolic is innocent.
This is innocent murmur.
Yes. So first is that it is a very low grade murmur. Okay. So when I'm saying that congenital heart disease, the only thing I may think of is because of murmur. But again, the murmur is very low grade. It's actually 2 by 6 murmur. And second one is there is no gallop rhythm. They did not mention about any added sound even in the lungs. They said there is no gallop rhythm. There is no bilateral basal crepitation. Anyway, those were not mentioned. That is, chest is clear. Second one, and the most important one, is that there is no hepatomegaly, and hepatomegaly is one of the surest sign of heart failure. So no hepatomegaly. Only for the murmur we were considering it. Okay, so we have three differentials. First one is septic shock, second one is neck, and third one is neck. Along with that, third one is our meningitis, fourth one is congenital heart disease. So what about congenital heart disease? We said that only because of the thrill that is only because of the murmur we are considering, right? But then there are no features. This child is particularly coming to us with shock. There are no other features of congenital heart disease. It is just as clear, no hepatomegaly. So we are excluding congenital heart disease. For meningitis, we have only 2 points in favor. The raised temperature is slightly raised along with that apnea. We'll keep that in mind, but considering the situation, the child is actually in shock. So this is also not the most likely diagnosis. Now tell me, there is only 2 things left, okay? There is sepsis and necrotizing enterocolitis. What do you think? Which one should we go for? Which one are we considering more? Can necrotizing...
It could be either. It could be either. So that is why we would investigate further to see.
Okay. So when we say necrotizing enterocolitis, can the child develop sepsis due to neck?
Yes, child can develop.
100%. Yes. So see, if we say sepsis, that means these are the points we are considering for sepsis. But sepsis would not cause, if I'm considering, isolated sepsis, of course, there is always a reason for sepsis. There is always a locus, right? So if I'm saying that this is a case of septic shock, yes, correct. But that means I have only these points, but I don't have anything to say, or I don't have anything that could explain extended abdomen or prematurity, absence of bowel movements. Okay, so sepsis, if I'm saying septic shock, that would not explain the abdominal sign and symptom that we are seeing here. However, if we consider necrotizing enterocolitis, that would actually mean the child, because the child was premature, was on formula feeding, which are the 2 important risk factors for necrotizing enterocolitis. In this case, the reasonable explanation would be the child actually developed neck, and from neck, the child develops sepsis, then from there, septic shock. So the reasonable explanation is the child developed neck, from neck, sepsis, okay, septicemia, and from septicemia, septic shock. So I'm considering more of neck. Actually, when I was reading this question, okay, up to here, that is up to this line, 2/6 systolic murmur, my differential diagnosis was, okay, this is a case of septic shock because temperature is raised, tachypnea, tachycardia. But the moment I saw distended abdomen with bowel sound, and then I just immediately reconnected that there is 26 weeks gestation, premature baby. So this is 100% a case of necrotizing enterocolitis leading to septic shock. Okay. Are we clear with this?
Yes.
Okay. So are we clear why did we select only septic shock? Features are sepsis, but because of these findings, that is distended abdomen and etc., along with the prematurity, that's why we're considering this is neck leading to septic shock. Okay. Now, so if we are considering this baby has come to us, what are the investigations you would do? So since I'm considering this to be a case of necrotizing enterocolitis, shouldn't I go for an X-ray, abdominal X-ray?
Yes, ma'am.
Yes, so I'll consider abdominal X-ray. And since it is a septic shock, definitely I'll go with a blood culture, right? So immediately, actually, I would consider abdominal X-ray. I would consider a ABG as well because there is tachypnea, tachycardia. For management purpose, I would go for an ABG. I would go for a blood culture. Okay. What are the other thing I can go for?
Full blood count?
Full blood count, very basic person. We can go with the full blood count. What about ECG, echo, cranial ultrasound? Is that all needed now?
No,
Not
we
required,
could go
ma'am.
with coagulation screen.
Okay, that we can do. But then in this case, if we are considering following the diagnosis, then coagulation screen and also no rash or nothing at all was given. So we'll not consider this immediately. Yes, among the list, this will be certain things we would like to exclude. But for the whole of the diagnosis and for the management, we will not consider coagulation as the first thing. Of course, it can be there in the list. Okay, so I thought of ABG is actually not there in the option, and because the child came with tachypnea, so I thought of abdominal X-ray, blood culture, and full blood count. Now if you look into any other option, that is lumbar puncture, so we had very little information which was supporting meningitis, that is a raised temperature and occasional apnea. Other than that, we didn't have any information that was supporting, there were no points more. The points favoring septic shock as well as neck were more as compared to meningitis. So this is not required. And moreover, this child is in shock. There is no way we can perform a lumbar puncture in this child. This is a ill child. Cranial ultrasound. Again, there are no features suggesting as such. Okay. Echocardiogram. So, the murmur is just 2/6 murmur. And in a sick child, in the absence of any cyanosis, or we are not considering any kind of congenital heart disease. In that case, echocardiogram will not be the immediate. Yes, we can later on do, but this could also be an innocent murmur. So we'll not go with the most appropriate answer. And they asked about investigation we would like to initially carry out. So basically, they are looking for the immediate investigations. Okay. Again, ECG does not require here in this case. Okay. So these are basically three things we'd like to choose. One is abdominal X-ray. Second one is blood culture. And third one is full blood count, as you suggested. Okay. Actually, I was not considering full blood count because I thought like that's very basic. But yes, you are absolutely right. This is required. Okay. What is the most likely diagnosis here? First one says group B, streptococcal sepsis, fungal sepsis, pulmonary hypertension, necrotizing enterocolitis, meningitis, pneumonia, interventricular hemorrhage. So as we discussed here, we did have some differentials, right? And we discussed this pneumonia, meningitis is out, interventricular hemorrhage. Actually, the child did not come with any kind of seizure. I don't know if apart from seizure, we could consider any point which would be, more fitting with interventricular hemorrhage or any kind of history, birth history, apart from the fact that the child was premature. Okay. So most likely diagnosis is necrotizing enterocolitis, and second differential, we can keep it as group B, streptococcal sepsis, that is leading to septic shock. Okay. Let's see the answer. Are we clear with this case? So this child basically presented to us with septic shock due to necrotizing enterocolitis. And what were the risk factors here? Two risk factors were there. One was prematurity. The second one was formula-fed baby. This is extremely, common question in exam, whether it is FOP, TAS or AKP, and always they will give certain kind of history that baby was premature. And even if they do not give these two history, they just say both history. They just say premature baby coming to you with abdominal distension. Immediately you have to think about neck, because prematurity is the first risk factor in case of neck. Okay, let's see the answer. Are we clear with this?
Yes.
Okay, let's see the answer. So the answer said this is a case of necrotizing enterocolitis, and nearly they selected all the options. And the explanation here is actually very short and good. This picture is a premature neonate, could be of any systemic sepsis, but neck is the most likely. Initial, because of the history given. Initial investigation would include abdominal X-ray, FBC, blood culture. Other investigation would need serum electrolyte, blood glucose, blood gas. So yes, we missed certain points. When we're thinking about what are the investigation we could look forward to, these are the initial investigation. We are 100% correct, but then there were some other investigations as well. That is, we would look into blood glucose as well as urea electrolyte. CRP may be helpful, which is usually raised in all kind of infections. Abdominal X-ray may show. So these are the findings in case of neck. Intramural gas in the portal vein. This is extremely important. And for some reasons in the exam, they always give this portal gas. Free gas, dilated or thickened bowel loops, and FBC may show thrombocytopenia and or neutropenia. And in case of management of this child, since this child is in shock, so we'll give a bolus of 20 ml per kg of albumin or 0.9% sodium chloride. Along with that, stop the enteral feed and commencing on IV maintenance, fluid broad spectrum antibiotic, cefotaxime or metronidazole, because it's a neonate, according to the local protocol. So in case of neck, this child is coming with septic shock, okay, and diagnosis is neck. So treatment of neck, immediately we'll go with the IV fluid, that is 20 ml per kg or sodium chloride. And in case of neck, what did we study? What is the treatment of neck? The first thing is stop feeds. The second thing is start with IV antibiotic along with that IV fluid. Okay. Stop any kind of feeding, you have to stop it. All kind of enteral feeding has to be stopped. Okay. That's it. We can check X-ray. Let me show a X-ray of neck. Yeah. Can you see this radiopedia? Okay, let me tell you something. Usually in the MRCPCH exam, most of the pictures, that's what I have found, most of the pictures are actually, at least if it's an X-ray, they are taken from this radiopedia. Okay, so if you're looking to practice for exam, look through the pictures of radiopedia. Yeah, this one. In fact, this exact picture, I believe, is there in one of the books. Okay, can you see there is portal gas? It's air in portal tract. It's written like in the liver itself, we'll find small. Usually it's not very clear, but this one is like very clear. Distended bowel loops along with that intramural gas. This exact same picture I've seen, I think, in case of illustrated book. Yeah, here as well. I wanted to show the portal gas mainly, because that is what commonly comes in exam. Yeah, here as well. It's not very clear with the portal gas. I'm specifically looking for portal gas because in all of the X-rays in the AKP exam, if they want you to indicate that this is a case of neck, they'll give something related to portal gas. Not able to find a very good picture, so we'll stick to the first one itself. Okay. Another important tip is that whenever you see any kind of X-ray in the exam, please consider the possibility of posterior rib fracture. Even if your diagnosis, even if the scenario is telling you this is a case of, say, foreign body inhalation, or this is a case of simply, say, this one of the common cases is congenital adenomatous malformation, or if they are saying it's about simply a case of pneumonia, consolidation, whatever it is, always please look for posterior rib fracture. Because usually they'll give you a scenario and then they'll ask you find the most important finding here. The reason is that I particularly missed this point in exam, and I could see only consolidation because that was correlating with the scenario, but there were another finding, there was a very clear posterior rib fracture which I missed. Okay, and it is their favorite thing to ask in exam. Let's move on to the next case. Okay, so first we'll see this particular picture. Actually, when I saw this picture, I felt like it's not very much clear, so that's why I don't choose a lot of cases related to picture. So the age of the child is 3-year-old. And can we appreciate anything on the X-ray?
Hyperaeration of lungs, ma'am.
Okay, here, right? You're thinking, okay, hyperaeration. Okay. Let me count the number of ribs here. Yes, there is hyperinflation. Okay, what else?
Steeple sign.
Okay, you can see stipple sign?
Ma'am, tubular heart, ma'am.
Okay, you're thinking it's tubular heart. Okay, we'll keep in mind. So you said there is a hyperinflation, which I also think I also agree with. And then you're saying there is a tubular heart. Okay. All right. This picture actually is not very much right, but all right, we'll keep that in mind. Now let's read the scenario. I'll disclose later why I'm telling that this picture is not very good. So first one is a 3-year-old girl 3-year-old girl presents with a fever for 2 weeks after a 3-month stay with relatives in Africa. She is not eating and has lost weight. She has developed a cough. On examination, she is pyraxial, has a generalized lymphadenopathy, and there is a palpable spleen. The chest X-ray is shown. Blood test shows hemoglobin is normal, WBC is again normal, slightly increased, platelets are normal, malaria slide is negative. Okay, this is very important finding. Now, let me pull out all the important points here. So we have a 3-year-old girl, and now she's coming with what is the important history and what are the important findings they're telling us. The important history is that she has a travel history to Africa. Okay. And now this child is coming to us with fever for about 2 weeks. Along with that, there is cough. She has developed anorexia. She's not eating well. There is a history of weight loss. There is lymphadenopathy. She is pyraxial. Along with that, there is splenomegaly. Okay, tell me. And blood findings are normal. The blood is good. Blood work is good. So depending on these particular clinical features along with the history, what is your differentials? What are your differentials? I should not be showing the differentials here. Tell me. When I thought of Africa, yes.
Tuberculosis.
Okay, very good. So when I thought of Africa, immediately I was thinking about malaria. But you know, they know our minds that that's the most important thing we'll be thinking about. But they completely excluded. So you're saying tuberculosis. Okay. What is the second differential? You start something by seeing the X-ray. Consider that. I'm giving you a hint. And see this weight loss, anorexia,
Bronchiectasis, ma'am.
Bronchiectasis. Okay. So the child did not come with repeated history. There was no history of short stature, nothing of that sort. So it could be actually bronchiectasis along with something else would require us to have a long
Ma'am, weight loss, anorexia, any
Lymphoma.
carcinoma?
Yes.
Lymphoma.
Yes, so we are considering any kind of malignancy. And I told you that look into the particular X-ray and you made a comment, right? That there were tubular heart. So upper part is basically tubular. Can you see this? Right? So I'm considering lymphoma. Okay. Any kind of malignancy because of the anorexia, weight loss, and lymphadenopathy. Okay. Then what else? What other differentials can we consider? A 3-year-old girl coming to us. Can we consider leukemia?
ALL, acute leukemia.
Yes.
ALL.
ALL, yeah, this is like, you know,
Leukemia.
clinically we have to consider this, but then again, they have excluded malaria slide. Along with that, the hemoglobin is normal, WBC normal, platelets are normal. So ALL clinically is not excluded, but depending on the investigation findings, will exclude ALL. Also, the slide they did not mention the presence of blast cells or something like that. But yes, clinically 100% we have to consider ALL in any child less than 5 years coming to us with anorexia, weight loss, and lymphadenopathy. There is also organomegaly. Okay, so we have two differentials. Anyone else have any differentials we can discuss together? Okay, we are okay with these three findings. Now, what do you think? What can we think about? What are the points in favor of TB?
Ma'am, prolonged duration of fever and anorexia, weight loss, lymphadenopathy.
And also there is a cough, right? They said that she has cough.
Mm.
Yes, that is there. And right now she's coming to us with pyrexia. So they didn't mention about that low grade fever in the evening rise of temperature as such, but now right now they are saying that yes, there was history of fever for 2 weeks, pyrexia was there, lymphadenopathy, etc. And are you considering TB because of history of traveling?
Not travel to
But in
Africa.
Africa,
Africa also, it's tuberculosis is very common.
Common, yes. South Asian country and Africa, you have to consider TB, malaria. So they already knew we would consider malaria. They excluded malaria. But TB is something you would consider even in South Africa. Africa is there means you will definitely consider South Asia and Africa.
Travel history, chronic fever, long duration fever, cough, weight loss, lymphadenopathy. First, we'll think of tuberculosis.
TB. If this was, they said that the child was in UK, there was no travel history, and coming with all these findings, then definitely we would think about lymphoma. That would be our first differential. Okay. If this was the case based completely on a developed country and with no travel history. But since they gave a travel history along with these features, that is anorexia, weight loss, along with that cough, fever, all of them are actually pointing more towards TB. Okay, that's why we are considering more TB. What about ALL? So as I said, clinically, definitely ALL is something we would consider, but the investigation finding shows it is already excluded. So most likely this is the case of TB, and child is presenting to us with pyrexia, acute episode, and lymphadenopathy, etc. What is the most important thing we would like to exclude at this stage? So we know.
Exclude Kawasaki.
Okay.
With,
No, I'm considering TB. I'm considering this is the case of TB because all the points are supporting along with the travel history.
But spleen, ma'am?
What about
Sorry?
Palpable spleen?
splenomegaly?
So organomegaly
Maybe this
can,
is push down spleen.
yeah, that is also possible because they did not explain anything about the size of the spleen or anything. Palpable spleen. So usually if it is just
Okay.
palpable, that time itself usually it's the double the size. So I'm saying that okay, my diagnosis I have made that because if the child came with a history of traveling, that's why I'm considering TB. As compared to lymphoma, I'm considering TB more. So say this child has come to me and I'm thinking this is TB and coming to me with high grade fever, she's pyrexial. In that case, what is the most important thing I have to keep in mind apart from starting the anti-TB? I'll give you one more hint. The child is coming with TB. Along with that, that is a pyrexia. Along with that, the child is drowsy. Now tell me. This is the case
TB
of TB.
meningitis.
Yes, TBM. We have to exclude that. Okay. We have to exclude that. So even though this is not there, this is a case of TB, but any sign of drowsiness, convulsions not improving, even after doing that, any kind of signs of meningeal irritation, immediately we have to keep that in mind. So the diagnosis is, I think, is 100% TB, but then these are the points I would keep in mind. Okay, so they're saying what are the main differential diagnosis to consider in this case? They're asking for two
Lymphoma.
answers. Yes, lymphoma.
And miliary TB.
Yeah, miliary tuberculosis, even though the X-ray is not very clear, but we'll consider this is a case of miliary tuberculosis. Okay. What about alpha-1 antitrypsin deficiency? Alpha-1 antitrypsin deficiency usually comes to us with respiratory. We'll also solve a case related to alpha-1 antitrypsin deficiency. They usually come with respiratory symptoms along with that features of jaundice. Jaundice usually comes later. No such features are there. Then we have vaginous granulomatosis. What are the clinical features of vaginous granulomatosis? This particular one, actually, there is another clinical case. I think yesterday I was solving. It had one of the differential diagnosis was vaginous granulomatosis.
URTI.
Okay, so there should be some history of URTI. What else?
Renal involvement also will be there, ma'am.
Usually, yes, renal involvement, there is lung involvement, there is conjunctivitis, usually there is some pericarditis. It's very common. What about Lyme disease?
There is no specific rash.
There is no
Erythema
specific rash. There is no involvement of the nervous system. There is no involvement of nervous system, no rash, etc. Lymphoma and tuberculosis, these are differentials. What about Kawasaki disease? So again, for Kawasaki disease, the crash and burn, right? This is our formula for Kawasaki is crash and burn. Usually burn means the history should be, burn means fever should be for more than 4 days. Apart from that, this is conjunctivitis, which is non-purulent conjunctivitis. There should be a rash. There is lymphadenopathy. There is strawberry tongue. Along with that, hand and feet desquamation. So we don't have anything of this sort. Yes, we do have the lymphadenopathy, but other than that, no other features are there. There should be actually 4 features plus history of fever for more than 4 days for us to convince that this is a case of typical Kawasaki disease, because there are atypical forms as well. So this is also absolutely out. Okay, so we are keeping two differentials in mind. One is TB, one is lymphoma, but I'm considering more of TB because of the history. What investigation would help you to confirm the diagnosis?
Chest X, CT chest.
Chest X-ray is already done.
Done. Montogram.
Monto. So we are considering TB, then obviously the first thing is that we'll go with the Montox test. What is the second?
And bone marrow.
Okay. You're considering bone marrow to exclude lymphoma.
Yes, ma'am.
Ideally, it would be lymph node biopsy. Okay. But then there is no option for lymph node. Because I was considering, okay, if it's lymphoma, I would consider the lymph node biopsy actually. I would not go immediately to the bone marrow. Okay. So we are considering Montauk's test along with bone marrow. So most likely this is a case of TB presenting to us, considering the given information. Okay, we are also keeping malignancy in mind. Are we clear with this case? It's a very shadow case. Usually in AKP exam, the best thing is that they used to give us that, select any 2 answers, select any 3 answers previously. But from this September attempt, again, they are going to make it all best of 5 answers. So, when you're solving questions, what you do is that even right now when you're practicing, I would suggest write TB and lymphoma, right? You can't have 2 diagnoses in best of 5. That will be 1 diagnosis. Before, you could go for 2 things, 2 options. Sometimes some of the questions they would ask for 2 options. So make a list and see which points are characteristic point of TB and which points, how many points you have in favor of TB, how many in favor of lymphoma. Whichever you think has more points in favor, go for that particular diagnosis. Okay, because obviously this is there, we have 2 options here, but in exam, from exam point of view, it's not suitable. Okay. So again, they have the similar thought as us. It was miliary tuberculosis, lymphoma, and investigation would be Montauk's test along with bone marrow. Okay. The X-ray shows typical features of miliary TB, widespread lung infiltrates, but then we could not appreciate it in the given picture. Even though they are saying the X-ray is showing miliary tuberculosis features, but we could not appreciate. Giving a snowstorm appearance, I could not understand that this was a snowstorm. We'll see another X-ray. Other features suggesting miliary TB but not shown in this X-ray are hilar lymphadenopathy and lobar infiltrate. So hilar lymphadenopathy is extremely important, very commonly asked in exam. So both things, extremely important. If they want you to find, they will definitely give some of the other finding on the X-ray. For AKP exam, commonly they give this widespread appearance, that is snowstorm appearance, as well as hilar lymphadenopathy. Although the history and examination are suggestive of lymphoma, the chest X-ray does not show the expected bilateral hilar lymphadenopathy. Neither TB nor lymphoma would show diagnostic change on blood count. So from the given information, we cannot completely consider that this is TB or lymphoma. Malaria cannot be excluded on a single thick and thin film. At least 3 should be performed if there is a real clinical suspicion and the history. So TB can be suspected with a positive Montauk's HIV test in the absence of BCG vaccination. So we'll go and ask forward with the history of BCG vaccination. If the child is not BCG vaccinated, then in that case, we'll go forward with the empty test. But may also be falsely negative. Sputum and gastric aspirate culture for mycobacteria may be falsely negative, and a result can take up to 6 weeks. Biopsy of the liver or bone marrow with appropriate staining can often lead an early diagnosis. But this is so invasive, we would not go with, biopsy of the liver or bone marrow. We'll go with the MT test. After that, we'll go with the sputum. If the child is able to expectorate, then sputum. But this is a 3-year-old, most likely we'll have to go for a gastric aspirate. Similarly, the histology of biopsy lymph node would confirm a diagnosis of lymphoma. So if we're considering lymphoma, we should actually go with more of biopsy of the lymph node rather than the bone marrow, because bone marrow will only show changes if there has been malignancy. Like now, there has been metastasis. Before that, if it's the early episode, most likely you would not find any kind of changes in the bone marrow. In this case, the patient had, so now they are giving some updates. Patient had a weekly positive Montox and responded dramatically to anti-tuberculosis therapy, making a biopsy unnecessary. So since they responded to the anti-tubercular therapy, that means they considered this is a case of TB. Mycobacterium tuberculosis was cultured from the gastric aspirate, and full sensitivities were obtained 5 weeks after the therapy was commenced. So again, they also gave the explanation and they gave us a review that basically this was a case of TB, miliary tuberculosis. Okay. I'll just quickly show you guys miliary TB on the X-ray because these are usually common cases in exam. Okay, can you see this? Grainy appearance all over, snowstorm appearance. Along with that, I feel like there is a right-sided hilar lymphadenopathy also slightly. Okay, this is extremely common in exam. See patchy opacity all over or snowstorm appearance. Then they also ask for the hilar lymphadenopathy in exam. Yeah, this is very good. See this? Both sided, there is bilateral hilar lymphadenopathy. All right. Okay. Now we'll go back to the case. All right. Now let's move to our next case, 1.3. Are we clear with this particular case?
Yeah, good.
Okay. Okay. Let's move. This is okay. Case number 1.3. A baby boy was admitted to the neonatal unit because of prematurity. So he was born at 35 weeks of gestation. If less than 37, we consider that premature. And low birth weight about 1.7 kg, so 1,700 grams. He was commenced on nasogastric formula feeding, which were gradually increased in volume to 150 ml per kg, 24 hours by day 4. And he remained alert and active and was tolerating feeds well without any vomiting, but was noted to have lost more than 10 kg, 10% of birth weight. So his feeds were now increased to 200 ml per kg for 24 hours by day 6. At the age of 8 days, he had lost 20% of birth weight and appeared dehydrated. A blood gas was taken at this point. So I know that if you look into the blood gas, you'll be able to make a slight diagnosis. Anyway, so we have pH is acidosis, carbon dioxide is reduced, there is base excess increase, blood glucose level is 63 millimole. This is the thing I was telling you. If you see this particular blood glucose, you'll be able to make the different diagnosis. 63 millimole blood glucose. Okay, forget about that. Now let us say what are the information that the case is providing us. So we have this baby who has come to us with history of prematurity, 34 weeks, along with that low birth weight. All right. He was on angio feeding and he was doing well. He was getting initially 150 ml per kg. By day 4, he remained active, alert. But then the main problem here was that he was losing weight. So on day 4, he was losing about 10% of his birth weight. By day 8, he was losing 20% of his birth weight. So extremely alarming. Increasing, even after increasing the feed, he was losing weight. Okay. See here. On day 8, 20% of the, and he appeared extremely dehydrated. Okay. Dehydrated and losing weight in spite of increasing the feed. Okay. Along with that, we saw there is severe acidosis, along with that increase in the blood glucose. What are our differentials? If we didn't consider the blood glucose, then what would be our differential?
Neonatal diabetes.
Okay, that is when we are seeing the blood glucose, that is when we are considering more of neonatal diabetes, right? I'm
First
saying,
will
say,
be sepsis. First will be sepsis.
okay. So because of losing weight, but the child, they said the child remained alert and active. Can we consider sepsis then? Because there is only dehydration and they
Then
look.
in inborn error of metabolism because
Okay.
of severe metabolic acidosis.
Okay, yes, because the findings are there, severe metabolic acidosis, so we can consider any kind of inborn error of metabolic disorder. What are the other differential we can think of? Can we consider renal disease? Bartter syndrome? Can we? There is one point given here which is going against Bartter. Bartter usually comes with the alkalosis. So there is no alkalosis, as well as no history is given of diarrhea or anything of that sort. They're saying he's simply losing weight. Okay, they did not mention anything of diarrhea, vomiting, nothing of that sort. So we are excluding the renal cause. What other thing we could do to exclude the renal cause?
Renal function test.
Urinary sodium.
sodium,
Sodium.
If urinary sodium is more than 20 millimole, then we have to consider, okay, maybe it's not Bartter, but there is some renal loss. There is inability of the maybe immature renal tubule or any kind of dysplastic kidney or anything of that sort. Okay, then we have to consider. We can simply do urinary sodium instead of doing all the set of entire, renal function test, and we can exclude that. Okay, so I was considering even renal disease as well. Okay. Now the third thing, that now my blood glucose is there. Now considering the blood glucose is high, what is my differential diagnosis? My diagnosis, considering the blood glucose, is it's a case of neonatal diabetes mellitus. Okay. Well, I was also considering a transient neonatal insulin resistance.
Possible.
That is also possible. But, this is a bit unlikely given the history of his birth weight. First thing. And second thing is that they ate. Usually, if it is transient neonatal resistance, by 1 week, it would get normal. Transient, because it's like for only up to 1 week. At max, it goes to 2 weeks. Considering that, this is less likely. Okay. Then they said neonatal diabetes mellitus. Okay, we are keeping that in mind. What about medium chain acyl-CoA dehydrogenase deficiency, fatty acid oxidation disorder?
Age, ma'am, age.
Okay. Another thing is very important. It's given here. In case of fatty acid oxidation disorder, what do we have? We have non-ketotic hypoglycemia. This child is coming to us with hyperglycemia. Child is alert and active. So in case of fatty acid oxidation disorder, mainly we have non-ketotic hypoglycemia. This is a case of hyperglycemia. So can we exclude that? Yes, we can consider other metabolic disorders, but fatty acid oxidation disorder or this one is completely excluded. Okay, either most of the cases come to us with history of fasting intolerance. Along with that, age is also important factor. But what we, from the given information with this glucose, this is very less likely. Okay, because all the glucose will be consumed, right? They don't have fatty acid oxidation. Okay, what about insulinoma? Why not a insulinoma? Why are we not considering that this could be a case of, insulinoma, excessive production of insulin from any kind of tumor or something like that?
It will present with
Weight gain will be there, ma'am.
hypoglycemia.
Repeated hypoglycemic episodes. And in that case, what is the glucose infusion rate limit we have? If the glucose infusion rate is more than 8 to 12, in one of the books it's written 8, another book it's written 12, more than 8 to 12 milligram per kg per minute. If it is higher than that, then we have to consider that either it is insulinoma or persistent or hyperinsulinism. So, and from the history itself, they didn't give us any history of repeated history of hypoglycemia, as well as the investigation finding here shows the blood glucose is very high. So this is not working. Congenital pancreatic agenesis. I'm actually not sure about this condition, so I'll not comment on this. If anybody has any idea related to this, you can share. Next one is fatty acid oxidation defect. So again, in case of fatty acid oxidation defect, we'll again find hypoglycemia. Non-ketotic hypoglycemia is a common feature along with fasting intolerance. They did not give any features of hypoglycemia here, no history. Along with that, the blood glucose is pretty high. So it is actually a very simple case, and this case is also mentioned. When you go for solving the recalls of AKP, you will see it's written that new format case 1.3, because it is one of the important questions in exam. The child will come to us with features. Now, I'm considering the diagnosis from exclusion is this is a case of neonatal diabetes mellitus. Okay. Oh, I'm sorry about this. Just a moment. Okay. So this is a case of neonatal diabetes mellitus. How is the child presenting to us? Can I say this is a case of neonatal diabetes mellitus presenting to us with features of DKA?
Yes, ma'am, because of acidosis.
Severe acidosis there is weight loss. Along with that, blood glucose is extremely high. So yes, this could be a case of neonatal diabetes mellitus presenting to us with DKA. Okay. Now let's look into the explanation. They didn't have a lot of information in this case. See, this baby has neonatal diabetes mellitus. It's a rare condition, incidence of 1 in 400,000 in the UK. Baby is present with intrauterine growth retardation. That's the reason the baby had a birth weight of 1,700 gram, followed by severe failure to thrive, hyperglycemia, dehydration along with within the first 6 weeks of life. That's why they are considering neonatal plus 2 months extra. In most babies, the condition is transient and resolves at a median age of 3 months. However, they are at higher risk of type 2 diabetes later in life. An abnormality of chromosome 6 can be identified in most familial cases and 70% of sporadic cases. And many of the sporadic are due to paternal uniparental disomy of chromosome 6, both inherited from the father. This is basically again imprinting disorder, or due to duplication of part of chromosome. Yes. So this is a case of neonatal diabetes mellitus presenting to us with DKA. Simple. Again, we need to look into the ketone levels, right, to consider that this is a case of DKA. What can be considered as the medical management, immediate medical management in this case?
IV NS, ma'am.
Yes, IV fluid, because again, 20% dehydrated. If it is more than 10% itself, we consider. Before in the guidelines, they used to have 5%, 7%, 10% dehydration, mild, moderate, severe. Now it's only 7 and 10% dehydration. 7 is moderate, mild to moderate, and 10% dehydration. They call it a case of severe dehydration. So this child is having with 20% weight loss. Along with that, that means obviously he's having severe dehydration. Severe dehydration, we'll go with the IV fluid normal. In case, do you think we should go with 10 ml per kg or 20 ml per kg?
20 ml per kg initially.
Per kg, slow correction of acidosis, otherwise it will lead to cerebral edema.
I was thinking about 20 ml because they gave appear dehydrated. But again, if it is like only say mild to moderate, not severe, then we'll not start, because again, as sir said that yes, it can, we have chances of cerebral edema. So initially we can go into 10 plus 10. Like slowly we can split it into 10 ml plus 10 ml. If there are features of shock, if they say severely dehydrated, or if they say lethargic child, no activity, something like that, or has not passed urine, then we could go with 20 ml. But when they said appeared dehydrated, like did not say much, only appeared dehydration, so we don't know if it is moderate or severely dehydrated, and also chances, because of the chances of cerebral edema, we'll keep it 10 ml plus 10 ml. Slowly we'll give 10 ml, we'll see the response after the 10 ml per kg again. What else can we do? Because now we are treating this as a case of DKA.
Insulin, we start insulin infusion.
Infusion with
In case of
0.5.
DKA, first one is IV fluid. After that, this is the bolus fluid we are giving. We'll start with the maintenance plus deficit fluid. Maintenance plus deficit. After 1 hour, we'll start with the insulin. Not before that. And whenever we are going with maintenance plus deficit, along with the 0.9% sodium chloride, what is another electrolyte we're supposed to add? 20
Potassium
milliliters
chloride.
of potassium chloride with every 500 ml of
ml of IV.
Remember that. Okay. All right. Let's move to the next case. This is extremely important. I think this comes almost in all the papers in endocrinology. Okay. Let's move to next case, 1.4. This one I found to be very, very interesting. See this, we are not looking into the differentials. Please don't look into differentials or ignore it. Okay. So we have a female infant was born at term by normal delivery following a pregnancy that was uneventful apart from influenza-like illness 2 weeks prior to delivery. Okay, she became unwell soon after delivery. Persistent pulmonary hypertension of the newborn was diagnosed and was treated with high-frequency ventilation and nitric oxide pulmonary vasodilator. She responded well and was extubated after 5 days. She commenced on enteral feeds on the 4th day of life and achieved full feeds on day 9. Okay, good and well. She was noted to have progressive jaundice from 10th day of life onwards. On examination, include a large broad forehead. Please listen to this carefully. Large broad forehead, a straight pointed nose, deep set eyes, a soft systolic murmur, and hepatosplenomegaly. Okay, now I'll highlight the important points. It's a female infant. She was born at term. Even though mother had a history of influenza-like illness, 2 weeks before the delivery, the baby came out to be very much unwell, and she was diagnosed as a case of persistent pulmonary hypertension of the newborn. Okay, and for that she was treated with nitric oxide and high frequency ventilation. All right, now she responded well, and after 5 days she was extubated. She was commenced on enteral feeds. 4th day of life, achieved full feeds on day 9. That means by the 9th day, even though she was not very well immediately after birth, she developed persistent pulmonary hypertension of the newborn, PPHN. She was treated and she responded well. End of story here. But on day 10, now she presented to you with jaundice on day 10. Along with that, on examination, you are seeing large, broad forehead, prominent nose, deep set eyes, and there is a murmur along with hepatosplenomegaly. So I'll not consider the previous history because the child was well, okay. But right now the child is presenting to us with certain dysmorphic facial features, right? Along with that, there is jaundice. Along with that, there is hepatosplenomegaly. And this dysmorphic facial features of, a large forehead, pointed nose. I'll just give one more hint to you. I know if I give this hint, you will be able to do it. Triangular face.
Alagille syndrome, ma'am.
Yeah, actually, it's not exactly triangular face. It's more of prominent chin. The chin is very prominent, okay? Very pointed. So that's why it looks like a triangular face. Okay, I knew that you would immediately answer. So why are we considering Alagille syndrome? We can consider it
because
to be... Tell me.
Facial features, dysmorphism.
Dysmorphic facial features. Okay, so we'll go one by one. So why not alpha-1 antitrypsin deficiency? So, her initial history about the pulmonary hypertension, or, we can consider antitrypsin deficiency, but antitrypsin commonly comes with history of respiratory tract infection, and then after that they come with jaundice. But antitrypsin is not associated with any kind of dysmorphic features. It's usually absent in alpha-1 antitrypsin deficiency. We're keeping Alagille in our hand. Now, what about biliary atresia? Can we consider this could be a case of biliary atresia because child is coming to us with jaundice?
But day 9 is not less likely, ma'am.
Okay. And one important history they have not given us for us to consider biliary atresia apart from jaundice.
Direct
Pale stool.
Direct biliary.
Yes. Pale stool, then direct hyperbilirubinemia. Anyway, they did not give any kind of investigation findings. I'm saying from the history, they just gave us jaundice. If they would tell us about something like pale stool, then we would immediately consider biliary atresia. Because sometimes, the patient may not be very much aware. They may come with late presentation. Maybe the child is having presentation since birth, but then you may find the child later. I remember there was this case in my hospital, and the child came like at 2.5 months old, and the child came with severe jaundice, and mother had only one history that my child has jaundice. So I was asking, why didn't you come earlier? And she said that we thought it will be fine after some time. And on examination, there is, after taking the diaper, I had to take the diaper because the mother did not feel it significant. She was having pale stool. So this could be the only history that is presenting from birth, but they could present to you, come to you later. They may not be, aware of it. So it's okay, 10th day of life, she's coming to such a history. So biliary atresia, because of absence of pale stool, we are excluding. What about Wilson's disease? Is this possible first differentials around this age in neonatal life?
Very early present.
Very
No, it
less
will not
likely.
present so early.
Yes, absolutely. So in this case, we are not considering Wilson's disease because this is such early presentation. Wilson usually presents in adolescent, at least after the age of 8 to 9 years. So that's why we are not considering this as a case of Wilson's disease. Neonatal cholestasis, is that possible?
No,
Which is
ma'am.
again,
No pale stools.
yes. So this is also again similar to that of biliary atresia. So neonatal cholestasis again would lead to features of pale stool, because if there is a cholestasis, if there is like any kind of obstruction, so ultimately bile will not be able to pass, that would produce pale stool. Digeorge syndrome, because there's this dysmorphic features are there along with that jaundice. Do you think this is Digeorge syndrome? Digeorge usually does not come with jaundice. Yes, dysmorphic features, but they are not even pointing towards digeorge. Okay, digeorge usually have hypertelorism, not deep set eyes, hypertelorism. They usually have fish-like mouth, and jaundice is not associated with it. Digeorge is commonly associated with hypocalcemia due to parathyroid hypoplasia, right? Along with that, what are the other features? They'll come with some kind of history of congenital heart disease, along with history of cleft lip, cleft palate. Nothing of that sort was given. Along with that, yes, there is parathyroid hypoplasia, thymic aplasia. So due to parathyroid hypoplasia, the child develops hypocalcemia, can come to us with seizures. Then there is thymic aplasia. Due to that, the B and T cells will not be mature, so child will come to us repeated history of infections. Then congenital heart disease, the child may come to us with murmur. History of cleft lip or cleft palate repair, that is also possible. One of the recalls I keep telling in class, because I saw this in my exam and that was the first time I have seen probably. The scenario was described in this way, that a child is like some few months old child, had history of repair of cleft palate. Okay, and I remember the scenario was about 3 to 5 lines. Usually when you look in the recalls, there's a lot of missing information because it's understandable, you can't remember everything after exam. So something was like history of repair of cleft palate. Now child is coming to you with seizures plus a murmur. Even if they did not give murmur, history of repair of cleft palate along with that seizure due to hypocalcemia should allow you to think about a case of Digeorge syndrome. And they give a quite big scenario with a lot of information, but you need to know that you need to highlight the most important points. If you do not know, like the eyes cannot see what the mind doesn't know. So if you do not know the features of Digeorge, no matter what scenario, no matter if it's an easy scenario, you won't be able to identify. Okay, so this is very contradictory from Digeorge syndrome, so we are not considering Digeorge. Okay, now let me show you a picture of Alagille syndrome. Okay, what can we see?
Pointed chin.
Pointed chin.
Disease.
Pointed chin, we can see jaundice, sclera, and then deep set eyes. Yes, pointed chin is very prominent. What are the other findings they are showing us here? The first one is some finding in the eye, posterior embryotoxin. What about the second one? Commonest anomaly in case of Digeorge.
Pulmonary stenosis.
Hmm.
Oh,
Digeorge,
no.
Sorry, Alagille. I'm saying Alagille. Peripheral pulmonary stenosis. That is usually the commonest anomaly, but it can come with VSD as well.
Butterfly vertebra.
Yes,
Allegedly.
yeah, very commonly they'll ask about. Now, there are 3 things they ask in exam, okay? Peripheral pulmonary stenosis is something they don't ask in part 2 exam because it's very basic. Alagille syndrome is associated with peripheral pulmonary stenosis. Commonly, they ask about this butterfly vertebra, okay? I think I'll go for a better picture, butterfly vertebra, I'll show you. Because this is again one of the findings. Okay. Yeah, this one is very nice. Okay. Yeah, this one is also very good. It's like the wings of butterfly on both sides, you can see. They look like wings of butterfly. Okay. So these are the things we'll consider, that if we are considering that, okay, this is our diagnosis from exclusion and from the given points, whatever it is, we have some dysmorphic facial features along with jaundice, hepatosplenomegaly, most likely this is a case of Alagille syndrome. Okay. Now, what deficiency in this child is at risk and how would you prevent it? So in this child, what do you think, what deficiency is there?
Fat soluble vitamins, ma'am.
Yes, because in case of Alagille, commonly it comes to us with jaundice. What kind of jaundice? Conjugated. It is associated with many kind of biliary tree abnormality, usually biliary tree obstruction. So the child will come to us with conjugated hyperbilirubinemia. Along with that, whenever there is again any kind of obstruction in the biliary tree, then we'll consider the possibility that bile is not there. So this child will not be able to absorb fat and fat soluble vitamins. As a result, child will suffer from deficiency of fat soluble vitamins. So we'll give supplementation of fat soluble vitamins. Okay. But if I'm thinking about conjugated hyperbilirubinemia, along with I'm saying there is kind of obstruction, that can lead to this particular jaundice, then why not biliary atresia? You already told the answer. Why not biliary atresia? Why not neonatal cholestasis?
Mm.
Dysmorphic facial features. Like there are more points. Again, if we go for making a list, there will be more points in favor of Alagille than biliary atresia or neonatal cholestasis, because there is dysmorphic facial features are not features of neonatal cholestasis or biliary atresia, completely excluded. Whereas Alagille is a syndrome which again comes with many different features together. So it already presents with case of hyperbilirubinemia due to any kind of biliary atresia as well. Okay. So this is basically a case of Alagille syndrome. And please remember this particular picture. I found this picture to be very nice. Pointed chin. Okay. And they said that sharp nose here. And this case, I found it has so good information related to Alagille. Like all the other books, that is, especially the ones that is mentioned, usually the ones that we follow for the Royal College exams, for the pediatric exam, I did not find any other book have had this much information about Alagille. It's so beautiful. All the information that you need. See here. So they're thinking the diagnosis is Alagille syndrome and fat-soluble vitamins. 4 major categories of differential diagnosis are suggested by the history. They are congenital viral infection. So in that case, what congenital viral infection are we thinking about? Torch, right? CMV mainly, because of the jaundice. We can think they're saying about differential diagnosis because this child was like, they said that there was a history of influenza-like illness 2 weeks apart, like before 2 weeks of being born. So after that, the child is coming to us with jaundice. We can consider a case of CMV, but again, she did not present with jaundice immediately after birth. So there is another, points against CMV. Then bacterial sepsis, group B streptococci, that is also possible because due to any kind of infection, the child can have jaundice. But these both again will not present to us with dysmorphic features. So they're just giving differential diagnosis. It's not confirmatory. Inherited metabolic disorders such as galactosemia, yes. So galactosemia can come to us with hypoglycemia, along with that hepatosplenomegaly, doll-like facial features, and galactosemia is very commonly associated with sepsis. Okay. Biliary obstructive disorders such as biliary atresia, extrahepatic and intrahepatic, that is also seen in case of Alagille syndrome. So these are the 4 differentials we'll usually find in this case, considering the findings they give us. However, the dysmorphic features suggest Alagille syndrome. So this dysmorphism is actually the star in this particular case. You see the dysmorphic features, that's it, your diagnosis is changed. Information about the stool and urine would be helpful, and total direct serum bilirubin concentration should be checked. Why this would be helpful? If we consider biliary atresia again, then we could ask about this. If they gave any other information regarding pale stool, dark urine, then we would consider biliary atresia alone. A liver biopsy showing the bile duct hypoplasia would confirm the diagnosis, and other investigation and would need to be done to look for associated conditions. Why? What are the other conditions they would look for? Echocardiography, because peripheral pulmonary stenosis or ventricular septal defect is very common in case of Alagille syndrome. Radiograph of the vertebra to see butterfly vertebra, the one we saw. Eye examination to see posterior embryotoxin and optic nerve drusen. DNA analysis, basically which gene is responsible, JAG1 gene mutation. So they are saying that once you're suspecting this is the case of Alagille syndrome, basically you will treat the intra and extrahepatic obstruction, same like biliary atresia itself. Apart from that, to prove it is a case of Alagille syndrome, we have to look into the associated disorders because it has a lot of features, right? Fat malabsorption secondary to chronic cholestasis is associated with the risk of fat-soluble vitamin deficiency. So we'll give fat-soluble vitamin supplementation. Along with that, medium-chain triglyceride supplementation is also required. So I wanted to say this, but it skipped my mind. Along with the fat-soluble vitamins, you also need to give medium-chain triglyceride supplementation. Neurological sequelae of vitamin E may occur despite treatment. So what is the neurological features due to deficiency of vitamin E? This is an important question even in the exam. Guys, we studied this.
Peripheral neuropathy, ma'am?
Ataxia.
No. Oh, ataxia. Okay.
B12 is a peripheral neuropathy. So I'll tell you one case. They usually give such cases in exam. They will say you, the child had history of jaundice. Okay. The child had history of jaundice. Now child is coming to you with ataxia. When they say history of jaundice, this is mainly due to biliary atresia or any kind of obstruction. Okay, in biliary atresia or any kind of obstruction. And due to that obstruction, there was decrease in the bile flow. And due to decrease in bile, there was lack of or deficiency of vitamin A, D, E, K. And E deficiency in long term causes ataxia. Okay, so these are the common scenario in exam. They'll say child had history of jaundice or pruritus, and now coming to you with ataxia. What is the cause? Vitamin E deficiency. The one you said, peripheral neuropathy, that is due to vitamin B12 deficiency. Okay. Alagille syndrome is dominantly inherited, so it is autosomal dominant, and they give some inheritance anyway. These are the signs of Alagille. Very beautifully written. See, growth retardation. So the child will come to us with a proportionate short stature, prominent forehead, frontal bossing, deep set eyes, hypertelorism. This is the one I was telling you that in the other book, there was hypertelorism. Picture was given, I think, in illustrated textbook. Posterior embryotoxin, prominent nasal bridge, peripheral pulmonary stenosis or any kind of congenital heart disease, signs of hepatic dysfunction, jaundice and scratch mark from pruritus. Vertebral arch defects such as butterfly vertebra, hemivertebra, rib anomalies, and hypogonadism. What are the associated features? Renal anomaly, hypoglycemia, mild mental retardation in about only 15% of cases, and pancreatic insufficiency. This is another important thing, pancreatic insufficiency associated with allergy. It's a very, very beautiful case. I found it to be very beautiful because it's like so wholesome. It had all the information. I mean, the dysmorphic feature was a cherry on top. You could just immediately diagnose. But the answer sheet, usually the answers in these cases are not elaborated. They're very short answers, 1 or 2 para. But this was the best information I found on this case. Okay. All right, we'll go to our 5th case and last case, 2.14. Okay, I have to be very careful about choosing. I don't want to see the answers. 2.6. 13. 2.14. All right. Okay, so this is in the format of EMQs. Even though we'll not have EMQs in the exam, but we are discussing to enrich our knowledge, right? That doesn't matter. So we have in the options, there are 10 options. Usually in exam, they used to give 10 options. Cystic fibrosis, Wiskott-Alrich syndrome, congestive cardiac failure, Cardiac syndrome, Bartter syndrome, Swachman-Diamond syndrome, Fanconi syndrome, Diamond-Blackfan syndrome, partial anomalous pulmonary venous drainage, congenital cystic malformation of the lung. So 10 differentials are given to you. Now, each of the case scenarios, for each of the case scenarios, select the most likely diagnosis. Okay. So we'll see each of the case scenarios. We have a 10-hour-old male neonate, term infant with a birth weight of 3.2 kg, noted to be grunting. Antenatal progress had been uneventful, although situs inversus was noted on the scan. The Apgar score was 7 at 1 minute and 10 at 5 minutes, so uneventful. No resuscitation was required. On examination, temperature was 35.8, heart rate 130 beats per minute, respiratory rate 35 breaths per minute. Oxygen saturation in air was 96%. He was grunting and had a capillary refill time of 4 seconds. Heart sounds were normal and femoral pulses were palpable. On chest auscultation, there was bilateral and equal air entry with some intercostal recession. Blood gas was normal and the grunting settled with warming. So basically, this was not exactly grunting, maybe the child was shivering along with that. However, he continued to have signs of respiratory distress with tachypnea and recession and an intermittent supplemental oxygen required for several weeks. The chest X-ray revealed scattered streaky shadows in the lung field, but otherwise normal. And ultrasound showed a structurally normal heart with a left-sided liver and aorta. Okay, so we have this case. Again, I'll just highlight the important points. We have a 10-hour-old baby, term infant. Birth weight is normal. The baby came to us with grunting. And situs inversus was noted on the antenatal scan. Otherwise, it was uneventful. Apgar score was normal at 5 minutes. No resuscitation was required. Temperature was 35, lower than normal. And heart rate normal. Respiratory rate again normal. The oxygen saturation was well and good. The only problem was he was grunting and capillary refill time was 4 seconds. Okay. Heart sound and everything was normal. Femoral pulses were palpable. They are saying femoral pulses is palpable. So this child is basically coming to us with features of shock. But they are excluding about any kind of congenital heart disease. What are they trying to exclude by saying that femoral pulses are normal?
Coarctation of aorta.
Coarctation of aorta. That's the thing they're trying to exclude. On chest auscultation, bilateral and equal air entry. So no problem in the lungs. And they're saying that blood gas was normal. The grunting, they're saying it occasionally it was improved with warming, but he continued to have signs of respiratory distress with tachypnea and recession and intermittent supplemental oxygen requirement for several weeks. So even though it was completely fine, after that now he's developing respiratory distress with tachypnea and he requires oxygen. That means saturation is going down, and chest X-ray is revealing streaky shadows. Along with that, a normal heart with left-sided liver and aorta. What is the diagnosis?
The only clue is
Situs
situs inversus and
inversus.
cardiac syndrome.
How is it
Complete
present? You're correct, 100%. With the situs inversus itself, we can understand this is the case of cardiac syndrome. But presenting with what? Cardiac is composed of two things, right?
Yes, ma'am.
Presenting with pneumonia and sepsis, something like that.
So cardiac is composed of primary ciliary
disease
along with that situs inversus. This together makes up cardiac syndrome, right? Now primary ciliary dyskinesia basically will come with history of respiratory infection. So with this child, if this is a neonate, then I'll consider pneumonia. I'll consider the history of bronchopulmonary dysplasia, but then the baby was born at term, no mechanical ventilation. So pneumonia, as I said, it is the most likely diagnosis. If it was an older child and all these features were there, I would consider this to be a case of bronchiectasis. Okay, because it's a neonate, so I'm considering this child is basically presenting to us with pneumonia. Okay, and I'm breaking down the component. This is a case of Cardiogenic syndrome, and Cardiogenic usually has two things in combined. One is situs inversus with primary ciliary dyskinesia. The primary ciliary dyskinesia part usually presents with history of respiratory tract infection, frequent. And in this case, considering the age, we're considering this could be a case of pneumonia. Okay, so our diagnosis is number 4, which is Cardiogenic syndrome. Do we agree? Any other differentials that you can think of? With the
After
side.
seeing all this liver on the left side, aortic arch left,
Yeah,
it becomes pretty clear. Otherwise,
clear.
if these things were not there, then maybe we can think of congenital cystic malformation or something else.
Yes, any kind of lung disease. We could have thought about that. You're right. So because it was made too clear with all the scans and after that ultrasound findings, etc. So this is most likely a case of Cardiogenic syndrome presenting to us with pneumonia. Okay. Next one. A 3-month-old breastfed boy was seen in hospital at 4 weeks of age. Okay. At 4 weeks of age, he had been admitted to the hospital appearing pale. He had a hemoglobin of 2.9 gram per deciliter. He was also neutropenic. Extensive investigation revealed that his immunoglobulin to Epstein-Barr virus was positive. Epstein-Barr virus, one of the important findings in Epstein-Barr virus, it is blood finding, will be neutropenia. This particular question, I think, came in the recent 2024 TAS exam. At 3 months, he weighed 3.7 kg with birth weight was good 2.9 kg. His skin was dry and flaky, okay, and his stool were loose, pale and pungent. So here again we have here pale stool, okay. He had received 2 courses of oral antibiotic from the GP for upper respiratory tract infections. So there was history of repeated upper respiratory tract infection. Chest X-ray was, however, normal. So sweat test were as follows. What is the conclusion for the sweat test? Why we are doing sweat test? Because they are considering
Cystic fibrosis.
cystic
Cystic
fibrosis.
fibrosis.
In that case,
More
what
than-
should be the level of chloride?
more than 60,
More than
more than
60.
60.
More than 60 millimole per
60
liter
millimole
is
per liter.
indicative that it's this case of cystic fibrosis. But here, see, the level of chloride is only 14. Okay, and if it is between 40 to 60, then we'll go with repeating the investigation again. If there are clinical features indicative of repeated respiratory tract infection, pale stool, that is features of pancreatic insufficiency plus respiratory tract infection, along with that, failure to thrive. In that case, we would consider again repeating the investigation. So this is not even indicative. So cystic fibrosis sweat test is negative. Okay. So now
Sweat test, it is chloride concentration or sodium concentration?
sodium concent no sweat
Sodium.
chloride concentration chloride
Chloride
sweat
concentration.
chloride concentration, yes.
Okay.
So see this case, 3-month-old coming to us at 1 month of age at 4 weeks of age, presented with paleness and hemoglobin is very low. So there is anemia. He also had neutropenia and he's tested positive for Epstein-Barr virus and birth weight and everything was normal. His skin is now dry and flaky. Along with that, now he's coming with pale stool. So pale stool, pale, loose, pungent stool. What does this indicate? Bile deficiency.
Cholestasis. There is cholestasis.
Cholestasis, okay, or I can say
Cholestasis.
pancreatic insufficiency. That is
Insufficiency.
Pancreatic, exocrine pancreatic.
exocrine, absolutely. Exocrine pancreatic, because if I say endocrine, that would mean insulin. I'm saying exocrine pancreatic insufficiency because again, it is associated with fat digestion and absorption. So see here, had received 2 courses of oral antibiotic because there was history of upper respiratory tract infection. Now it's normal. So what can be obtained from this child is that this child is coming to us with pancreatic insufficiency, exocrine pancreatic insufficiency, along with that anemia and neutropenia. So I would have considered Epstein-Barr virus infection, but apart from the neutropenia, I don't have anything else clinically to support that this is due to Epstein-Barr virus, because they have given that child is positive, immunoglobulin M positive. Okay, so I don't have any other clinical finding to support that diagnosis. However, this particular finding of anemia as well as neutropenia, this is showing pancytopenia or bicytopenia, at least I can say. From the findings, I don't have all the blood findings. I don't have the thrombocytopenia. I don't have the WBC or the differentials. And say there's a case of pancytopenia or bicytopenia along with pancreatic insufficiency. And what did we study in class? Two things. PP, pancytopenia plus pancreatic insufficiency equals to, oh my God, guys, Suchman-Diamond syndrome. Diamond syndrome. Okay. Usually this one, Diamond-Blackfan syndrome. What are the features of that? Why are we not considering Diamond-Blackfan syndrome? That can come to us with aplasia, that is pancytopenia, okay, or aplasia at times, but it is not associated with pancreatic insufficiency. Pancreatic insufficiency with pancytopenia or bicytopenia can only be seen in case of Suchman-Diamond syndrome. That's why we are considering more of this. Okay, so we also have the option here. So this is option number 6 here. Okay, remember pancytopenia, PP, pancytopenia plus pancreatic insufficiency. This is the case of Suchman-Diamond syndrome. Okay. Again, you would say it's not pancytopenia because all the findings are not given. You have to, because this is theoretical, we have to make the diagnosis based on whatever is informed or whatever the information is given to us. Okay. Next one. A 6-month-old boy was referred by the GP with a cough and weight loss. He had a cough on and off since birth and vomiting for 2 weeks. His weight had dropped from the 50th centile at birth to below 3rd centile. The cough sometimes produces green sputum. He was born at term and was well following birth. He was admitted at 2 months with persistent cough and blue episodes at the end of coughing. Basically, cough-induced apnea. Then we have nasopharyngeal aspirate was negative for respiratory syncytial virus after 5 days. He was sent home. On examination, he was afebrile. Heart rate was 110 beats per minute. Blood pressure 85/60 millimeter of mercury. He was tachypneic with a respiratory rate of 40 breaths per minute. For a 6-month-old, is it okay, 40 breaths? Or are we considering this to be over? For a 6-month-old, this is tachypnea. His oxygen saturation was 86 in air and had intercostal recession, but a clear chest and auscultation. Skin was loose and looked very malnourished. The initial blood test shows sodium low, hemoglobin normal, potassium low, WBC slightly increased, urea normal, platelet normal, creatinine normal, pH alkalosis, urinary sodium normal, bicarbonate is again increased. So I'll just highlight the important findings here. Okay, it's gone. Okay, hello. Can you guys see the screen?
Yeah, we can see, we can see.
Okay, so basically this 6-month-old child has come to us with repeated history of respiratory tract infection with cough. Along with that, there is history of weight loss. Okay, this is the history. And now he is coming to us. There is different episodes where they said that he was coughing. At the end of coughing, he was developing apnea, etc., etc., and they excluded respiratory syncytial virus anyway. Now he is coming to us with history of respiratory tract infection with cough along with that weight loss, and he is also developing, poor saturation. The chest examination is clear. Along with this, this finding are very much diagnostic of a condition. Repeated respiratory tract infection
Cystic
along
fibrosis
with
syndrome.
failure to thrive. Yes, it's a case of cystic fibrosis. Along with that, we may also see features of pancreatic insufficiency, that is loose stool. However, they did not give any information regarding the bowel movements. They said that there was, his birth weight dropped from 50th centile to below third centile, etc. So he's coming with repeated history of respiratory tract infection, coughing, along with weight loss. Now he's developing poor saturation. Basically, he's developing cyanosis. Okay, and see the investigation findings. This hyponatremia, hypokalemia, hypochloremia, chloride is not given, along with metabolic alkalosis. This is seen in which syndrome?
Pseudo-Bartter syndrome.
Pseudo-Bartter syndrome. So pseudo-Bartter syndrome, usually what are the pseudo-Bartter syndromes? Cystic fibrosis, pyloric stenosis, and
Stenosis.
congenital chloride losing diarrhea. These three belong to pseudo-Bartter syndrome. Okay, Bartter means it is a renal disease. Pseudo-Bartter means it is not renal. That's why we call it pseudo-Bartter. And we have one important investigation here, which is showing us this is not due to renal cause. This electrolyte abnormality of hyponatremia, hypokalemia with pH alkalosis, etc. One investigation is given here, which is saying us this is not renal cause. See here, the urinary sodium is only 5 millimole. If it is more than 20 millimole, then we'll say that, okay, the renal system or the kidney does not have the ability to absorb. So that will be considered as Bartter. But since urinary sodium is less than 20, we are happy, our kidney is absolutely fine. This is not Bartter. This is a case of pseudo-Bartter syndrome, basically cystic fibrosis. Okay, why we are saying cystic fibrosis? Cystic fibrosis because of respiratory tract infection along with the weight loss. Okay, and why is it developing cyanosis? What can we think of? Which respiratory infection?
Bronchiectasis, lower respiratory.
Bronchiectasis. So ultimately, one of the features of cystic fibrosis, usually they by the age of 1 year, you will see this child is developing bronchiectasis, and they'll come with certain features. One is frequent episodes of cyanosis, respiratory tract infection, and on examination, you may find that general examination clubbing on fingers. Okay. So you will see that whenever we see cyanosis, we consider, okay, maybe it's a congenital heart disease, but then considering the history, we have to go on excluding one by one. And these investigation findings are absolutely diagnostic of pseudo-Bartter. Okay. So this is a case of, first one was cardiogenic syndrome. Basically, again, they said situs inversus along with suggest primary ciliary dyskinesia and cardiogenic syndrome, etc. Second one is also about Swachman-Diamond syndrome, and all the points that we made were actually mentioned here. Cystic fibrosis here. So this one is interesting. The most likely diagnosis is pseudo-Bartter syndrome caused due to excessive sweat electrolyte loss in undiagnosed cystic fibrosis. So pseudo-Bartter has three things we have to remember. Okay. In cystic fibrosis, chronic sweat chloride loss may be aggravated by intercurrent illness, precipitating metabolic consequences. There is a lack of adequate salt intake to counteract the loss of the sweat, etc. So anyway, this is the case of pseudo-Bartter presenting with cystic fibrosis. I would like to keep the pseudo-Bartter term rather than directly saying cystic fibrosis for the exam. Okay. Say this child has come to me with repeated history of respiratory tract infection with failure to thrive. So the diagnosis cystic fibrosis. Another child came to me with repeated history of vomiting, and in spite of vomiting, the child is always hungry. Now tell me, what is this?
Pyloric stenosis.
Pyloric stenosis. To be specific, I'll call it projectile vomiting, but I just wanted to confuse you. So I said vomiting and hungry. Okay. Then another presentation is that child is coming to you with history of diarrhea for about 2 to 3 months. Otherwise, he is well grown. So you'll consider the possibility with the electrolyte findings, congenital chloride losing diarrhea. Usually it's a self-limiting condition. The child will be well grown. On examination of the sweat, you will find the chloride concentration is high. So whenever we have hyponatremia, hypokalemia with hypochloremia plus metabolic alkalosis, in that case, we'll consider pseudo-Bartter. This is your investigation findings. Then according to history, you will define which pseudo-Bartter. If it is respiratory tract with failure to thrive, like in this child with features of bronchiectasis presenting with cyanosis, then it's a case of cystic fibrosis. If vomiting, projectile vomiting, along with that, in spite of vomiting, child is hungry, pyloric stenosis. Okay, if child is coming to you with diarrhea, along with that no other abnormalities, then most likely congenital chloride losing diarrhea. This is also very, very important. Okay, we're okay with this case?
Yes.
Okay.
Okay, so we'll end the class here. Thank you so much for the participation.
Thank you. You please try to
Thank you.
continue with this. Don't go by reducing participation. Okay.
No
If
problem,
the
no problem.
participation is going down, so then don't
No, it's
discontinue it.
completely fine, because I do
Yes, sir.
understand some people may not be available for entire 1.5 hours. So that's why I thought of, taking on the most easiest cases or cases that would increase the participation. But I'll continue this, no problem.
Thank you.
Thank you so much.
Thank you.